Let us see some physiological concepts in respiratory medicine. Again, these physiological concepts will be discussed in your integrated physiology, but I want you to have some basic knowledge to understand various clinical diseases. So the first physiological concept is, around your lung there is a covering called as pleura. So within that always a pressure is generated. What is that pressure within the pleural space? Called as intrapleural pressure. So first physiological concept is the intrapleural pressure. So write down intrapleural pressure, also called as IPP. So my lung always tries to recoil towards the center. Your lung is a very good elastic structure. Now suppose there is a spring, I am stretching it to some distance and I am placing on the table. After some time, will that spring be still in that stretched position, or will it come back to its normal position? It will come back to its normal position. In the same way, your lung is a good elastic structure. So the tendency is always to recoil towards the center. And they have noticed the chest wall's tendency is to move outward. So the lung's tendency was to recoil towards the center, and chest wall's tendency is to move outward. If these two things are happening simultaneously, your inspiration and expiration will not be comfortable. To balance these two opposite forces, in between there is a balancing pressure called as intrapleural pressure. This intrapleural pressure will bring lung to an equilibrium volume, chest wall to an equilibrium position, so that your inspiration and expiration is comfortable. So this intrapleural pressure is a balancing pressure which brings lung to an equilibrium volume, chest wall to an equilibrium position, so that your inspiration and expiration will be comfortable. So between these two opposite forces there is a balancing pressure. There is a balancing pressure. So this balancing pressure, it is called as negative. It is called as negative intrapleural pressure. It is called as negative intrapleural pressure. Why the name negative? When they have measured this pressure, they found out it was slightly less than the atmospheric pressure. In respiratory physiology, we take reference atmospheric pressure as 0. See, anything less than 0 is negative. Anything more than 0 is positive. Actually, it is not a proper negative pressure. When they have measured the pressure, it was less than atmospheric pressure. For calculation convenience in respiratory medicine, we take atmospheric pressure as 0. Because it is less than 0, it is considered as negative intrapleural pressure. And this intrapleural pressure has most important function. Its prime function is to always tries to maintain equilibrium lung volume. Always tries to maintain equilibrium lung volume. So this equilibrium lung volume is called as relaxing volume. Also called as functional residual capacity. Relaxing volume, also called as functional residual capacity, that is FRC. So this intrapleural pressure always tries to maintain equilibrium lung volume. It is also called as relaxing volume or FRC. So this FRC I will discuss in spirometry. When they measured the pressure, they found out it was not same throughout the lung. In the apex, it was more negative. In the base, it was less negative. They thought this regional difference was due to influence of gravity, but exact reason is not known. In the apex, it was more negative, minus 10 centimeter H2O. In the base, it was less negative, minus 2.5 centimeter H2O. They thought this regional difference is due to influence of gravity. So this intrapleural pressure is something happening in all of us, in all of our bodies, around our lungs. There is a covering called as pleura. Within that pleura there is a pressure called as intrapleural pressure, and what is its function? To maintain equilibrium lung volume. Let us see conditions where this intrapleural pressure can alter. So more negative intrapleural pressure, less negative or positive intrapleural pressure. So let us start with more negative intrapleural pressure. More negative intrapleural pressure. So during deep inspiration, less negative or positive intrapleural pressure. It can happen during forced expiration, cough, Valsalva maneuver, Valsalva maneuver. Now what is the reason behind this? Now deep inspiration. See, everything school level physics, everything here that we are going to discuss is whatever you have learnt in your school level physics and chemistry is sufficient for understanding respiratory physiology, is what I feel. So now deep inspiration. So whenever I take deep inspiration, air from the atmosphere has to accumulate in my lungs. Now if air from the atmosphere has to accumulate in my lung, what should happen to pressure around my lung? Around my lung it should be more negative. The reason is gases generally flow from high to low pressure. Now during deep inspiration, excess air from the atmosphere has to reach the lung. So around your lung what should happen to the pressure? It should become more negative. So during inspiration there will be more negative intrapleural pressure to follow the laws of physics. So more negative pressure generated so that air can get accommodated into the lungs easily. Now during forced expiration, now consider there is a balloon completely filled with air in your hand. Now I am asking you to expel the air out without breaking the balloon. So what will you do? You will press the balloon. So once you press the balloon, what exactly you are doing? You are applying positive pressure around the balloon to facilitate air to go out. Now in the same way, forced expiration, air from your lungs has to go out forcibly. So around your lung, just like pressing the balloon, there should be a positive pressure pressing your lung for that air to expel out. So forced expiration, around your lung positive pressure will be generated, just like pressing a balloon. Because of this positive pressure, air will swiftly go out into the atmosphere. Then why in cough? Why in Valsalva maneuver? What is cough? Cough is forced expiration against closed glottis. What is Valsalva maneuver? Valsalva maneuver is forced expiration against closed mouth and closed nose. So let it be cough or Valsalva maneuver or forced expiratory maneuver. So there can be positive intrapleural pressure. These are some physiological conditions. Let us see pathological conditions. We have something called as pushing lesions. So what are the pushing lesions that we will come across? We have pleural effusion, pneumothorax. Now what is the basis? Normally within your pleural space there will be about 5 to 10 ml of fluid. Now instead of that, if 1 liter fluid accumulates, excess fluid accumulation in the pleura is called as pleural effusion. Now this fluid can generate a positive pressure. So the fluid will generate a positive pressure and it will push the mediastinum to opposite side of the disease. So how will you know the mediastinal position, tracheal position and the apex bit? Now instead of fluid, if air accumulates, air can generate still more positive pressure, and that positive pressure will push the mediastinum to opposite side of the disease. So the pathophysiology here is excess fluid or air accumulated in the pleural space can generate a positive pressure. Now this positive pressure will push the mediastinum to opposite side of the disease. So write down mechanism, you will understand. Excess fluid or air accumulated, excess fluid or air accumulated in pleural space can generate positive pressure, Because of this positive pressure, there will be push of mediastinum to opposite side of disease. Here the logic is, disease is pushing the mediastinum, so it is called as a pushing lesion. Very simple, students. Now suppose there is right sided pleural effusion. What will happen to tracheal position? It will be towards left. If there is left sided pneumothorax, what will happen to tracheal position? It will be towards right, because disease is responsible for push of the mediastinum. So these are called as pushing lesions. So we have pleural effusion, pneumothorax. So whenever there are pushing lesions, what else should exist? Pulling lesions. What are the pulling lesions that you have come across, students, in your routine clinical postings? One is collapse, other is fibrosis. Let us see why they are called as pulling lesions now. Coming to pulling lesions. One is collapse and other is fibrosis. Now let us see what is common here. What is collapse? Collapse is airless lung field. Because there is no air in that lung, what will happen? The volume of that lung will decrease. So collapse is airless lung field. So the total volume of the affected lung can decrease. Now what is fibrosis? Suppose there is a damage to your skin. After few days there will be deposition of scar tissue. Now tell me, students, deposition of scar tissue, is it expansion of that area or shrinking of that area? It is shrinking of that area. In the same way, because of lung damage, there can be deposition of scar tissue, and this deposition of scar tissue will cause shrinkage of the lung. So these shrinking lungs are called as fibrotic lungs. So let it be collapse or fibrosis. Ultimately the affected lung will lose volume. There will be decreased volume. So these lesions are also called as volume loss lesions. Now whenever the volume of the lung is decreasing, so what is the pressure always trying to maintain the volume of this lung? It is your intrapleural pressure. So what will this intrapleural pressure do as a defense mechanism? It will try to expand this lung. So to expand the lung, what should be the pressure applied? It should be more negative. If it is positive pressure, it will compress the lung. To expand the lung, it is going to apply more negative pressure. As days progress, on the affected side, there will be more and more negative pressure. Now this negative pressure will pull the mediastinum to same side of the disease. So write down the mechanism, you will understand. To maintain equilibrium lung volume, more negative intrapleural pressure generated, that results in pull of mediastinum, to same side of disease, because disease is responsible for pulling the mediastinum. It is called as a pulling lesion. Now for example, if there is right sided collapse, trachea will be pulled towards the right side. If there is left sided fibrosis, trachea will be pulled towards the left side. Because disease is responsible for the pull, these are called as pulling lesions. Now I am giving you a patient. by seeing the patient, by inspecting the patient, only inspection, by seeing the patient, how will you say that this side of the patient is diseased? So he is having a unilateral disease. Now by seeing, by inspecting the patient, how can you say, how can you identify the diseased side? It is not tracheal position, students. Why it is not tracheal position? Because if trachea is shifted towards the left, it can be either due to right pushing lesion or left pulling lesion or left pulling lesion. Then what is the most important finding to localize the diseased side? See, suppose this is healthy hand and this is diseased hand. So healthy hand, diseased hand, which will move better? Healthy hand will always move better. Diseased hand cannot move better. In the same way, healthy lung will give good chest wall expansion. Diseased lung cannot give proper chest wall expansion. So to identify the diseased side, always localize the side of decreased chest movements. Write down, very, very important statement, student. To identify diseased side, localize side of decreased chest movements. Localize side of decreased chest movements. So to identify diseased side, always localize side of diminished chest movements. Localize side of diminished chest movements. Now I'll give you some examples. You only tell me what is the probable disease. So there was a 45-year-old male, okay, decreased chest movements, right side, trachea was left side. What can be the probable diagnosis? So there was a 45-year-old male. So his chest movements have been decreased on right side. So chest movements are decreased on right side. Trachea is towards the left. What can be the disease, students? So movements are decreased on the right, so it is a right sided disease. Whereas trachea is towards left, so it is a right pushing lesion. So it has to be either pleural effusion or pneumothorax. So it can be a right pushing lesion. So either pleural effusion or pneumothorax. Now how to differentiate these two? Just percuss, students. If you are getting a very, very dull note, it is fluid. If you are getting a very, very resonant note, it can be air. So later we will be having a special session on clinical examination. There I will discuss all this in detail. So this is how you should identify the pulling lesions and pushing lesions. So pulling lesions, collapse, fibrosis. Pushing lesions, pleural effusion, pneumothorax.